I'm going to address some of the newer data in targeted therapies in CLL and some of the unanswered questions. The BTK inhibitor Ibrutinib has really led the way in terms of targeted therapies, and I'm going to talk about some of the unanswered questions. Specifically, we do know that patients who relapse on Ibrutinib often don't do well, and we don't know best yet how to salvage them, which remains one unanswered question. Another unanswered question is that outside of clinical trials, more patients are stopping Ibrutinib than we would have thought. Perhaps as many as 30%, depending on age, due to various related adverse events. And so we need to optimize the management of some of those toxicities specifically for those patients so that we can keep them on the drug. Because we know that if patients do stay on the drug, patients who do not have high-risk abnormalities, they have about an 89% 3-year progression-free survival, even though they've had multiple prior treatments. So that's really quite an excellent outcome if we can keep them on drug. And there is some recent upfront data with Ibrutinib compared to chlorambucil, in which the 18-month progression-free survival for older, low-risk, previously untreated patients is about 90%, which is really quite good. Although we also know from the relapse data that for patients with one prior regimen, they have about the same 18-month progression-free survival. And so I think we're really waiting for further randomized trials with better comparator arms in the upfront setting to decide to move Ibrutinib upfront for most people. And I'm also going to talk some about the PI3 kinase inhibitor class, and in particular the drug Idelalisib. There was some recent news a couple of months ago when Gilead shut down some initial therapy trials involving Idelalisib because there was an excess of deaths in the Idelalisib-containing arm. Now, a couple of these trials were combinations with bendamustine rituximab, so they were chemo combinations. And most of the deaths were actually due to infections, sort of routine bacterial infections in the setting of neutropenia. And so I think actually if we look at the data with Idelalisib, we probably know that there have been issues with infections before, neutropenia, as well as opportunistic infections. And so this isn't hugely new, but there is a clear recommendation that we need to monitor for neutropenia, treat neutropenia with growth factors, give prophylaxis against pneumocystis and viral infections, and generally monitor the patients more closely than before. And in general, it would be best not to use Idelalisib in untreated patients until we better understand these toxicities. We've actually done some work where we've looked at the T cells in patients treated with Idelalisib in the upfront setting where we did see some significant immunologic toxicity, and we've shown that associated with that toxicity there's a decrease in T regulatory cells, which is what you would expect from mouse models. And so I think more work needs to be done on the pleiotropic immunologic modulating effects of these PI3 kinase inhibitors in order for us to optimize their use.